So my name is Dr. Kayla Rush. I am a seasoned infection preventionist certified in infection control. I'm a certified public health professional and a healthcare accreditation individual. And I also hold a PhD in epidemiology with all of my focuses on infection prevention and control education practices, training, and healthcare acquired infection reduction. And I work at TEPI, which is the Texas Epidemic Public Health Institute. And our goal here at TEPI is to really create a strong, supportive public health workforce by providing early detection, communication, training, and providing other education, such as infection prevention and control education, to individuals to really help prepare the Texas community for the next related infectious disease outbreak. So this lecture has been approved for continuing education for individuals that hold a certification in infection control, a CIC, an associate infection prevention certificate, an APIC, a certification in public health, a CPH, a CME, and a CNE. So to complete and get credit for your continuing education hour, you will need to attend activity 100%. So you must stay for the whole entire lecture, complete the learning activity and the post-test evaluation. And there will be steps at the end of the lecture that guide you through how to complete these steps and what you need to do in the format. So as I mentioned, this lecture is approved for continuing education for CMEs and CNEs. And also, if you are a certified health education specialist, a CPH, and an RS, and as I mentioned, if you are a certified infection preventionist, hold a CIC or APIC as well. As one disclosure, I am a consultant for a company called BD, and there is no financial relationship or promotion of any products during this lecture at all. So just wanted to let you all know this is a requirement for complete disclosure. So now that we have gotten that out of the way, today's learning activity objectives will be to describe and discuss the environmental care, which we will call as the EOC for the remaining of this lecture. We will discuss risk assessments and specifically the Joint Commission risk assessment, or the TJC, going forward through. So these are some common acronyms. And this is also a joint lecture between the P2R consortium and with the Texas Epidemic Public Health Institute, or TEPI, housed at UT Health Houston here in Houston, Texas. So let's begin. So what is the environment of care? So in the healthcare settings, environment of care is referred to the whole entire environment that has to do with patients, staff, visitors, anyone that comes into that hospital setting is, or healthcare, any hospital, long-term care, skilled nursing home, clinic, any or surgical suite, that is any type of healthcare environment that is all referred to as the environment of care. So there are specific regulations, recommendations to make sure that these environments relate to patient, staff, and visitor safety, security, infection prevention, and other emergency preparedness and readiness correspondence. So some of these regulations get overseen by different groups, such as the Joint Commission. They set EOC standards for any hospital that is opting into Joint Commission accreditation. We have our EOC standards that are put forward through OSHA, or the Occupational Health and Safety Administration, to make sure that these environments that deal with certain devices and procedures and exposure to bloodborne pathogens and other type of very pathogenic material, that we have standards set in place that our healthcare workers, which are any individual that's working in that environment, knows how to maintain safety while caring for these infectious patients. And then lastly, CMS, which is the Centers for Medicare and Medicaid, they have facility-wide regulations to maintain these safety standards and all these components. And the environment of care, which is a very broad and very encompassing topic, it covers all 8 of these domains, from emergency management, security, safety, infection prevention and control, utility system, hazardous waste, fire safety and life safety, and medical equipment. And we're going to talk about all of these in details of what that means in each steps. So the first big component is just the general safety management. And I've kind of broken it down into 4 subcategories when you're talking about safety management. You want to know hazard identification. So that can go from just how the layout is, what types of hazards are available. Those can be trips, falls, spills. Make sure that the floor is even, that there's good lighting, there's good documentation, there's no chipped flooring, the ceiling isn't cracked. That all goes kind of into hazard identification. So it's looking over at all the risks within the environment. Then we go into workplace safety. So these are specifically looking at our OSHA guidelines for healthcare safety. Last year in the 200 series, I presented lecture 202 on OC-EPI, kind of really talking about OSHA bloodborne pathogen exposure plan and our respiratory fit program, which are OSHA standards that all healthcare environments need to have. So we're not going to talk about those in details, but you can reference back to that lecture 202, which you can find on our YouTube TEFI channel for that. It also talks about workplace injuries, so not only our bloodborne pathogens exposures, but any time of ergonomic or OX safety injuries that you're lifting and you hurt your back, or you trip and fall at work and you hit your head. Those go under workplace safety as well. Next, then it's a hazardous material exposure. So in healthcare, we deal with a lot of things. We deal with chemo, we deal with pharmaceuticals, we have medical waste, we have infectious waste, non-infectious waste, we have carcinogenic products that we work with, making sure that those are documented and they are maintained in a secure location in the correct bins, that there's no spillage, leakage type of exposure. That all goes into workplace safety. And we kind of talked about that in our first series lecture in 102, talking about preparedness. We went into a whole section of how to calculate and maintain your infectious waste, what type of bins they should be in, where they should be located, how those are transported. So if you want a reference on that, go back to lecture 102 in detail that talks about that. Then we go into patient safety. So making sure that we have a fall prevention, so none of our patients are falling. But then also on the other part of it is that we are compliant with our restraints and our restraint documentations. That goes into our bed and chair alarms, making sure that our patients that are at high risk, that such have mental or cognitive delays or physical delays, such as the patient that has had a stroke and now they have decreased mobility on one of the sides, making sure that they're not getting out of bed unattended, since their gait or their walking might be off balance. So making sure that we have the bed alarms, chair alarms in place. And then of course, many things like we always talk about is hand hygiene. Hand hygiene will always be a safety event. It will be safety management. It's infectious waste, hazardous waste, maintaining, and infection prevention and control. So hand hygiene always hits in every single domain, no matter what type of safety component. And then it's a huge risk to the environmental care, making sure. As I kind of already talked about, environmental hazards, making sure that we know what's going on in our hospitals. And then we also are making sure that we have a water damage plan. We know our mold mitigation plans, any type of construction. We are here in Texas where we have a high humidity. So there's a lot of times there's likely for mold, leaks, repairs, damages from winds, from hurricanes, tornadoes, and other things. So making sure that we have a water penetration plan, a water monitoring plan, that we're looking for Legionella in our dead pipes. We also then have our air quality control, making sure our HVAC systems are being cleaned. They are maintaining their appropriate pressure and air exchanges per manufacturing, and how we're set up for our negative, positive, and neutral pressure rooms. And then making sure our chemical exposures, making sure that when we are working with chemo or any other type of volatile components that sometimes that we work with in healthcare, that making sure that we know how to handle them, not ourselves, but also how to store them in our environment until we can have the proper pickup for them. Next, we go into security management, which has to do with 4 subgroups of access control, surveillance system, violence, and theft prevention. Access control, making sure that we have security for sensitive areas. That could be our ICUs, that's our surgical suite areas, that's our medication rooms, making sure that we have right documentation, we have our badges, we know who to access them, we're completing the logs. We also are aware of very sensitive information or patient protected health information or PHI, making sure that they're secured and that we're only accessing that as needed and who needs to be. So not everyone has access to our EMRs, and making sure that you're pulling up the right patients in the right order. Surveillance system, making sure that we have security alarms, and it's being monitored 24/7. A high alert area is always our NICU or any time with our new infants and babies, making sure that we have alarms on them. We know where they are. It's a very secure area to try to prevent any type of infant abduction. And going into such as our surgical areas or where we have sterile processing, our surgical instruments as well, making sure that those systems are under surveillance. Violence prevention, making sure that we are protecting our staff and our patients, doing de-escalation trainings, workplace violence safety policies, procedures, and that we have a plan of action in case something escalates. And then lastly, going to theft prevention, specifically looking at medical supplies, talking about diversion of certain type of medication, equipment, and patient belongings. The next subgroup is hazardous material and waste. So it's chemical safety, biological, radio, and training and PPE. So making sure that we know how to handle our chemical waste. It is being stored according to our OSHA standards, along with certain documentations that are required with our chemical safety, that people are trained how to use it, how to store it. It is that leak through puncture resistant bins. It is labeled appropriately. And you are following the IFUs or the instructions for use for those types of materials. Biological waste, same thing. As I mentioned before, lecture 102 specifically goes into detail about how to handle that, along with safe practice for our needle sticks, which is our 202 lecture on OC-EPI, making sure that we know how to handle our sharps, where they go. We're not overstuffing the sharp containers. We know what is infectious waste and the difference between our waste of regular waste, infectious waste, our chemo waste, and that those bins are being maintained and not overstuffed. And then we have our pharmaceutical waste, and if they need to go in a black box pharmaceutical waste bin, that we have those, we know where they are, and again, we're not overstuffing them. Our radiation safety, always with our imaging, making sure that we know those areas, that they're secure, they don't allow metal, so we are making sure that our patients know that, our staff know that, so that we don't have any type of harm event in those areas, and that they are properly draping the PPE so they're not getting an increased dose of radiation working in those departments. And then lastly, everything goes into training and PPE. So making sure if you have to handle hazardous waste, you've had the proper training, it's documented, it's conducted annually, and those are maintained. Because especially when it's accreditation, either the Joint Commission is coming in for the triennial thing, or CMS is coming in either for accreditation, regulation, or for cause audit, that they will be looking at your training records and pulling your personnel. So making sure that those are in a central location, it's all up to date, and everyone is compliant with it. Next is our fire safety and life safety. So fire prevention, making sure that our electrical system, our oxygen and fire prone areas, that you know where your sprinkler heads are, there's nothing blocking them. That the golden rule for accreditation and for just life safety events is that there should be nothing within 18 inches from the ceiling. So when you're going into your storage room, nothing should be stacked or stored 18 inches from the ceiling. It's also that another regulation is that 6 inches off the floor, nothing should be directly on the floor ever, from an infection prevention and a fire and life safety. Making sure that our floors are free of slip, trips, and falls, and that they are illuminated. We know where to go. Next, with our fire detection, that those are being tested annually. They're being maintained. We have our smoke detector, our fire extinguishers, making sure that we know all about PACE and PASS, especially for those that not only see over the infection prevention and control, modules, but if you sit in the occupational health component too, and you're overseeing that program and within your facility, that you have this annual training, they know, and your fire extinguishers are being inspected every year. Evacuation procedures and protocols for all types of situations, from environmental to a hopefully not, but a shooting event in your facility or any type of lockdown, that you know where those are, how to handle them, and people have been educated on them, and then that you are within compliance standard for Fire Safety Joint Commission and CMS. Medical equipment management, so making sure that everything has gone to your biosafety or biomed, depending on what is called within your facility, that it is being tested. Your sticker on your device has your annual sticker of the date that it's in service. It has passed QC or quality control, and it is good within clean and effective operating condition to be put in circulation to be using on patients or for staff member. So making sure that we do all of our infusion pumps and making sure that we corral them every year, look at them, inspect them, making sure that they are cleaned and maintained appropriately, and then that they are functioning according towards manufacturer design, along with our defibrillators and our ventilators. Our equipment safety checks, making sure that everything is free from defects. So anytime that you are looking at a piece of equipment, no matter if it's a low level use or a high level sterilized piece of equipment, you should always be doing a visual check that there is no rust or debris there. It look is how it should, and if it ever does not look the way that you are familiar with it looking, or you think that there's something wrong with it, or there's some rust on it or biobuilding buildup, that you're doing a stop and a timeout right then and there, and making sure that you're inspecting the piece of equipment before using it on a patient. As I've already mentioned in some of the other components, making sure that you're training, that for a specific piece of equipment that you have been trained appropriately according to the IFUs, it's within your scope of practice. So depending on what type of licensure and what role that you serve in the hospital, that you are only using equipment that under your scope of practice, you are covered with your licensure, and then that there's proper documentation of education training. And then inventory control, making sure that you know how much you are having for equipment, it's stocked appropriately, you know where to locate them. That's also great for pandemic preparedness plans, making sure that you know where your PPE is, or if you have PAPRs, where they are, where they've been tested, everyone knows how to don and doff them appropriately. And that you kind of are paying attention that if you have to send out so many things, that you have a backup, and that, you know, if you only have 3 types of endoscopes, all 3 are broken at the same time, and then you have to send them all out, and you don't have one that you can use in your facility. So then you cannot do any type of endoscopic procedures for that. So making sure that you're aware of inventory control within your equipment that you oversee in your facility, and that meets all the infection control standards. Our next one, utility systems, so power supplies, any type of disaster management under the infection control and preparedness and readiness, making sure that you know how to handle. Do you have generators? Are they on backup generators? Do you have red plugs in your facility? What equipment needs to be on a red plug? Making sure that you're looking at that. And definitely when you're rounding and doing EOC rounds, when you're looking at your environment, that you're paying attention to this, making sure that you're walking into areas with this type of equipment and you're saying, oh, is this on a regular plug? Is it on a black plug? Is it on a white plug? What does that mean at your facility? How's that been designated? Should it be on a backup generator access or not? Is it okay if the power goes out, that piece of equipment cannot be used? Then looking at your HVAC system, as I mentioned, making sure that they're doing the appropriate air exchange, they've been cleaned appropriately, and your pressure within your negative, positive, and neutral rooms are being maintained. That's a one for patient comfort, and making sure that they have air and that they're not too hot, not too cold, which I know sometimes is really hard because some people run hot and colder, but it is a huge infection prevention risk, because those certain areas, such as our isolation rooms, there should always be negative pressure, meaning that the pressure out in the corridor is higher pressure, so it sucks everything in. So you don't want a patient to be in a negative pressure room and it not being maintained pressure, because then it's not going to hold the pathogens that that person will have. Like such for an example, you have someone with measles or with TB, they need to be in a negative pressure room. And if they are not, that if the door is opening and closing, you can then have the airflow kind of push out different particulates in of that pathogen into the common space, such as a hallway, and expose a bunch of other people. If you don't have negative pressure rooms in your facility, the best next thing for infection prevention and control is just to put a patient in a room and close the door. So at least then there's not as much airflow going back and forth, but anytime you open that door, trying to do it quickly so that you don't have huge spread of pathogen into the hall. Water systems, as I mentioned, making sure that you know where they are, your waste management, you have a water plan and you're being monitored, and then communication, making sure that you know how to communicate, when to communicate, your alerts, your alarms throughout your facility, within your unit, within your staff, all of that goes into utility management. Then it goes into emergency management, and these are kind of all things that we've already really touched on, but your disaster preparedness plans, making sure that you have readiness for all the things that kind of tied into your hazardous waste, your utility, your security, know what to do in case there is a situation, be prepared for it. And you're prepared by doing drills and training, depending on your facility. That could be every year, every 2 years, every 3 years, depending on what specific regulation that you're trying to meet. So making sure people know what to do. So in case when a situation happens, and it's not if a situation happens, it's when it happens, that you are prepared and your staff are feel comfortable accessing their emergency preparedness plans. They know what to do and they feel comfortable in that situation. Then another thing that happens with emergency plans is that you set up incident command. So knowing where that is in your facility, who's involved, if you are involved, a lot of time infection prevention and control representative will be in that command center. So making sure that you know what the policies or procedures are. If you're new to infection prevention, and especially if you're new to a leadership role, and maybe you've never been part of incident command, making sure then you ask your boss or the next person above you of in case something happens, how do we set that up at our facility? There's great trainings. There's a lot of FEMA trainings that people have done, but each facility I've seen has their kind of own way of setting up incident command, what that looks like, who the hierarchy is. And then that goes into your stockpiles as well, making sure you know where your PPE is, your food, your water, any backup power, and then making sure that you have communication. And then lastly, then we have the infection prevention and control. So a huge one that is always with the environment of care is hand hygiene. Hand hygiene. We know how to clean our hands. We know when to clean our hands. We know when to use our alcohol-based products first, water-based with soap and water. We know how to wash our hands. And it's being monitored and you have good compliance, especially if you are doing your joint commission or if you have opted into another optional accreditation of the Leapfrog and you're getting your Leapfrog rating of A through F. On that, hand hygiene is a huge component and a huge metric within that, where depending on your bedside, your patient population, and your average daily and annual census, you'll have a specific algorithm that will tell you how many hand hygiene observations and compliance level they will need to have to maintain a certain grading within the Leapfrog. Next, environmental cleaning, making sure that your environment is clean. You know the difference between daily clean, a terminal clean, and infectious clean. You're using the right products as an infection preventionist or anyone that's in charge of the infection prevention program. You know the difference between the different products. If it's an ammonia based, if it's a bleach based, if it's an alcohol based, what is the wet time or contact time for that specific product that needs to be used, and that you are aware and kind of focus on high touch surfaces, especially when you're rounding and you're going through the hospital looking at the cleanliness. You're looking at the floor, you're looking at the ceilings, you're looking at the walls, but then when you're going into patient rooms, you're looking at the bed rails, the sinks, you're walking into patient bathrooms, the toilet flush handle, the light switches, those are really high touch surfaces. So we're making sure that we know where they are, and then you're having your environmental staff or your nursing staff clean those more frequently. And then you know the difference between disinfection and sterilization for your medical equipment and what that involves in most of our, in some lectures that we have coming up later this year, 306 and 307 talk about the difference between high-level disinfection and sterilization. And we will be going over some of the new SHEA guidelines that just came out on those areas, along with some of the APIC material and CDC recommendations. So if you're a little rusty to high-level disinfection or sterilization, I encourage you to come to our future sessions, lectures 306 and 307 that will talk specifically about those areas of cleaning. And then our airborne precautions, making sure that you have HEPA filters, negative pressure rooms, isolation, they're properly identified. You fast track them or put them quickly into a room or quickly to be seen. They're not sitting in our lobbies in our very congregate areas. And then another big thing for infection control, we are doing surveillance on MDROs, CPROs, other high consequence pathogens such as measles, Mpox, H5N1, C. auris, any other type of pathogens that can be lurking in the community that we are screening, we're testing, and then we're tracking them along with our healthcare acquired infections or our HAIs, specifically our CLABSIs, our CODIs, C. diff, MRSA, and SSIs. Lectures 201 and 202 that I gave this year specifically talked about CLABSIs and C. diff. Last year's lecture 210 talked about CODI, different ways that you can work on improving those metrics. So if you are needing some help in that area of HAIs, I implore you to go look at those lectures for more material. So now that we've kind of done a basic background of what these different components are, let's specifically now, we know what the 8 areas are. What does the Joint Commission risk assessment look like, and what type of metrics are they looking within those 8 areas? So a little of this will be a little bit of repeat from some of the material that I've already talked to you about, but I want to make sure that it's solidified that within these sub areas, they put them as a risk level this way, and then these are some ways that you can mitigate the risk. So again, environmental care is in the whole entire environment, and there's multiple agencies, as I mentioned, OSHA, NIOSH, CMS, the National Fire Institute, and the FPA. They all have specific regulations to help mitigate the risks to patients, staff, and facility operations to ensure that we have a safe environment for everyone. So the Joint Commission, or TJC, use the SAFER matrix, which you see here, which is a specific grade looking at the immediate threat to life, and then they look at it as high, moderate, low, different categories to really try to give an idea of what type of risk level it is, and they will give you deficiency and citations based on this. If it is a high immediate or an IJ, that can result into, that would be the top right hand corner, the red box. That can lead to losing accreditation in your licensure with immediate and a specific action plan. So depending on how they're categorizing, there's different severe consequences, such as losing accreditation. And if CMS is coming in and says that you have failed and have a deficiency in this, you can lose all your CMS funding, which are millions and or billions of dollars at your organization. So knowing how they are categorizing things is really, really important, and also will let you know the priority of fixing that issue. So when they look at it on the scope of likely to harm, the scope of non-compliance, and then the high risk. So those are kind of the top areas that they really stratify it to, making sure that, you know, it's low risk, low occurrence, or high risk, high occurrence, which then might put you into that immediate jeopardy area. So this is kind of just like an example of how they look at it. So for our low category, then our definition of harm could happen, but would be rare. And then the further guidelines that it would actually be rare to an actual patient that harm occurred because of this deficiency. Then moderate is harm could happen occasionally, and then high is harm could happen at any time. So that's looking at those specific categories, and then just the more details of what that exactly means and their interpretation under the further guidelines. Then they look at the categories as limited, pattern, or widespread. So limited, making sure that like it only happens in a one specific area compared to widespread. They were looking at throughout the whole entire facility. So if it's a more widespread citation, that might have them put it as a risk level higher, compared to if it's limited, and it's a little bit higher harm, they might not put as much pressure on it. So it's kind of looking at the matrix, looking at the potential of risk. And then when you're talking with your C-suite about this, you always need to be using risk. That is what this looks as, is that a measure of risk. It's not a definitive yes or no, but it is that it could happen, and this is the probability of it. So when the C-suite asks you for a lot of hard numbers, you can't really give them a high. You can say the probability is looking at this. So always make sure that you're using that language, that this is a level of risk and this is a probability. And that's how, when surveyors are in looking at your facility, those are the type of language that they're going to use in the verbiage. So then this is just their safer matrix, which in the resources and references part of the slide deck, I have that listed, and it kind of gives you more examples of really what a moderate limited, a moderate widespread would be, how it looks at likely to cause harm, likelihood to cause harm, what that means, and then their scope of practice. So I thought this is just some good examples that the Joint Commission site has in their risk, and this is linked at the end of the slide deck too. And then also what they would categorize as a moderate widespread or a high limited area too. So making sure that they know. And one of these things, if they are in your facility and you're going through survey and they find this in one place, most likely they're going to go to a different unit, look for the exact same thing, and that's how they're going to determine it, if it's limited, if it's widespread, or it's moderate within your facility. So once they find it in one area, they're going to go check in another area. So just be prepared for that, to see then how they are going to categorize the risk. So that's kind of all the Joint Commission. And now we're going to kind of walk through some examples of what that looks like and what you can do when you are rounding and you see things with the next steps and mitigation techniques and strategies to address your EOC risk assessments. So as I've mentioned, and we've talked throughout the lecture on, it's the main components are identifying potential hazards, evaluating the risk, knowing how severe and the occurrence of them. Then the next step is going to be implementing mitigation strategies. And then you want to monitor, review, and document and report. So just like in healthcare, in anything, if it's not documented, it didn't happen, you need to make sure that you are documenting these findings. If there's a follow-up plan, if there's outcomes or changes of policies, procedures, training, etc. from this, because when they are in your facility and when you are going through surveys, they are going to ask you for that, and they're going to say, well, were you aware of this? And if you say yes, then they want to know, what have you done about it? So now we're just going to go through 8 specific examples, and then after that we'll go through kind of a fun learning activity before I open it up for questions. And I know this material is very dense, so I appreciate and implore all of you to stay with me on it. So the first one, for general safety risk assessment, our first way, as we kind of talked about what that looks like, is 1, identifying potential hazards. So when you are in a hallway, in an area, a unit, a corridor, etc., you want to look to see how cluttered it is. Are there beds there? Are there chairs there? Are there cords there? Are the cords improperly placed? A lot of times we have the covers over the cords on the floor, so it's not a tripping hazard. That's one thing to look at. Are there spills, and how is the lighting? So looking over at, I call it your 4 walls, from the ceiling to the wall to the floor to the other wall, making sure what is around you that you are looking at. Then the next step is evaluating your risk. How severe is this? Is this a high issue? Is it moderate? Is it overall a high impact? If you have a cord in a busy area that's not taped down and multiple people are going to fall, that's a high issue. So making sure when you are evaluating if there's any spills on the floor, that's also going to be a high issue. Are there signs? Have people know how to clean it up? Are the right people being called for these things? Next, then, our third way, if you see any of this, what can you do to mitigate them? So if you see any obstacles in your path, you are removing them. We're not having beds in the hallways, extra chairs, any obstacles that's obstructing our pathways. We're making sure our electrical cords are taped down. We are cleaning up spills immediately. If you see any type of fluid or debris, food, bodily fluid, anything on it, you are cleaning, they're signing, it's being discussed, and that the lighting is good. We don't have any dark hallways or blacked out lights anywhere. So it's clear of obstacles. It's good to walk, nothing in your way, you're not going to bump into, and it's good, you're not going to slip, and it's proper lighting. Next, then, if you see anything that then you are conducting safety audits and rounds, so going on environmental care rounds, looking, walking in this area, making sure that they're not just, removing the equipment and then literally after you leave, they come back and they put it back in. So following up on a daily, weekly, monthly, quarterly, annually, semi-annually scheduled. You're reporting the hazards, you are tracking it in your system. Some hospitals have great fancy EMR systems that you can put in a safety event report. You can put it in that. You might have with your environmental care round individuals, you might have a reporting system, that one, or just, pen and paper, send an email. That's another thing. If you don't have any fancy EMR system, just, being able to have a paper trail, an electronic paper trail saying that you alerted this, you talked to them, they removed it, you followed up on XYZ. That's another way. And then that you are collecting information from patients and staff. So asking everyone, how has this been looking? Has this been a problem? Have you noticed anything difference in the area? And then documentation, any type of logs tracking to ensure compliance. You want to make sure that you are doing that. With security management, so making sure that everything is secure, that we only have authorized personnel going into specific areas, that you have no blind spots in your camera. So making sure that when you're asking security, especially in very secure areas or any type of medication, specific equipment, certain areas such as like the ICU, a mother baby ward or a NICU nursery, those are highly secure areas. The OR, any surgical suites, any area that you are doing patient procedures, those should be secure individuals. Doors are locking, they are key card only. Doors are not being propped open. And that you're kind of, their security around staff, they have had their de-escalating training, that you're having these conversations. And then you're evaluating the risk level. So you're looking at if it's high, moderate, low, and what the impact is. And then you're mitigating these risks by, making sure that everyone has the right badge, they're wearing it appropriately. Every facility has a policy on, work appearance. Usually it's under HR or just a general policy, but most policies I've seen is that badges should be up on your shoulder, or on your chest. So that they're in sight, visible, so we know who is coming and going within the facility. Our security cameras are functioning, they're not stuck, they're not blacked out, so making sure that they are working effectively. Staff feel comfortable with de-escalation training, they know how to have a conversation to try to de-escalate certain activities. Then when you're monitoring, so you're making sure that you're conducting audits, you're reviewing incidents reports if there are situations that are coming up, and then that you're having recommendations for improvements on protocols to threats that you're seeing. So you're always documenting, tracking, and ensuring compliance with the standards. with hazard material, so making sure that you're identifying the problem, so making sure everything is properly stored and labeled, and they are segregated appropriately. So we have the infectious waste and the infectious waste, and we have the chemo waste and the chemo waste, and the pharmaceutical waste and the pharmaceutical waste, and we are not just throwing waste everywhere, because our logs that those go into and then how they are transported in and out of our facility, or not in our facility, but out of our facility and through our facility, there are certain training and documentation. So you, as I mentioned before, that waste needs to be handled and documented appropriately and handled appropriately. So you want to make sure you have the right stuff being maintained. And that if you're having any exposure to radioactive material, so you're checking with radiology of what's going on, everything is safe, there's no spills or chemical spills. Also with pharmacy, or if you do any compounding within your pharmacy, asking them how that's going, if there's any issues with their hood and their clean rooms. And then you're evaluating the risks to see, is it low, medium, high, or limited or widespread, and then putting in mitigation strategies. So making sure that you are compliant. Everyone knows about the OSHA compliant chemical labeling. That is a standard labeling. They should have all looked the same, and you should be using OSHA approved labeling for your chemicals, not just a piece of tape with some black Sharpie on saying what it is. No, don't do that. You making sure that you have your protocols are up to date and people know how to use them. If you have spill kits and your radioactive spill kits, you know where they are, though they are not expired, and staff feel comfortable using them. And then, like many things, you are conducting, monitoring, performing. So making sure that you're observing, you're seeing, you're tracking, you're documenting, and then you're ensuring compliance and maintenance. And you're just talking to people. They know where they are, they know what they're doing, and that, especially doing this regularly, will really help create an environment of safety and change within your specific facility. And then when you're getting ready to go into your survey, these things will be refresher and they won't be brand new, and really kind of help you prepare for your survey if you're in your triennial or your CMS like for cause survey. Next, for the utility systems, making sure that our water, power failures, and HVAC systems is all set up appropriately. There's no failures. We know what to do if there is a failure. We're evaluating our risks. We're implementing our mitigation strategies. So our backup generators, you are doing routine HVAC system cleaning maintenance. So if you're not sure how that is done, make sure you ask your engineering or facility folks of what type of schedule they have, how is that being documented. Most of the time for their air exchanges, the digital system that goes to their computer so that they know and they can look at it. But definitely ask them what they're doing at your facility. And then like anything, to monitor, conduct, and evaluate, and then to document, always maintaining logs. Everything that has a log, that should have a log, it should always be up to date, always being documented daily, to make sure that you're ready for compliance and if a surveyor walks in. For emergency preparedness, so making sure that you are ready for anything, for pandemics, disease outbreaks, so that you are looking at the news and our HANS, our healthcare alert network system alerts that we put out, other state and local community alerts. So you're working not only with your facility, but you're talking to your local health and the state public health of, are there any pathogens of concern in the area of what's going on, to see if you need to review your policy procedures, to know what staff to look out for, to do and to handle. You're then evaluating your risk and your severity, then putting in mitigation risks. So making sure that you have your plan, your protocol, you're conducting training, drills, doing tabletops, talking about backup power, water, and communications, especially if you're offline. How are you going to communicate and document in patient's chart? And your clinician staff, a lot of your nurses and your pharmacists and your MDs or DOs, PAs, NPs, they know what their downtime procedure is for ordering drugs, how to get drugs, how to do patient care when there's no power, if you have to go offline. And then making sure that they know who's involved in incident command and you know who's involved in incident command, if that is you yourself. Making sure that you know what to do, how to delegate other responsibilities. Like anything, monitoring, conduct, review, and update. And then for documentation, reviewing your logs, ensuring that you're tracking, maintaining insurance compliance with those. And then lastly, for infection prevention, our main things, our top big things is hand hygiene, making sure that you have good compliance, that you know how to wash your hand. Everyone knows how to wash their hands and use alcohol appropriately. There is appropriate environmental cleaning. You know the difference between cleaning, disinfection, high level disinfection, and sterilization. You're looking at your airborne transmission risk and proper ventilation, also throughput and identification of these patients too. And then making sure that you're paying attention to your PPE. People know how to don and doff. They're not cross contaminating, and you're not burning through your PPE at an appropriate level. Then doing your evaluation and then implementing mitigation strategies. So looking at best practice from WHO, from CDC, from your state and local health departments, making sure that you are doing audits, reviewing, looking at your environmental care, looking at your airflow isolation protocols, you're reviewing isolation daily, you know who your isolation patients are, and that they're on their correct precautions, and if they require negative pressure. And then everyone knows how to put their PPE on, and you're donning and doffing them. So then monitoring and then documentation as well, the same as conduct, monitor, and review, and then maintain, track, and ensure compliance. And then this is just more in-depth for our infection prevention and control risk assessment. So making sure when you're doing your infection prevention, this is just, I pulled a brief, a couple components. Ours is very detailed in all the things that we look at. But when we're doing our environmental care, we're making sure that everything's cleaned appropriately, it's documented. There's hand hygiene, nothing's on the floor. So 6 inches from the floor should be free. If you have any low shelves in your storage room, they are like fully, they have a complete barrier at the bottom. So the shelving that has the individual slits on the rows, that is not appropriate. If you have that, then there should be like a plastic or another barrier. Because the point of that is when you have it that close to the floor, dust and debris and soil from the floor will be kicked up. And if that shelf isn't solid and there's little sections of ways for particulates to get up through the shelf, you're going to have that first layer of stuff, whatever's on that low shelf, contaminated with dust and debris and particulates. And so then when you're grabbing and then taking it to the patient's room, you're contaminating the patient. Or if you're setting up for a procedure or taking it to any other place and setting it down, you are now cross-contaminating, taking those particulates, those dust and debris and pathogens on it. So you want to make sure that your floor, nothing should ever be stored under the sink. None of your bins should be overstuffed. It should be closed. Your linen should be in a leak-proof container. No porous bags, no tight.
5 minutes.
And then making sure that you're looking at your trays, they're not just scattered everywhere in your dirty utility room. Things are being wiped down. There's no obstacles or clutter in your ways in the hallways, and that your patient areas are clean, full of debris. They're being cleaned and disinfected appropriately with the appropriate material. And then when it goes into wastewater, waste management, we've kind of already talked about. Don't overfill, making sure that they're in the right bin. They are in a puncture-proof, leak-resistant container. CMS and Joint Commission will want those words, that it is leak-proof and it is puncture-resistant for all sharps and biological transportation, especially if you are transporting a device such as an endoscope, for reprocessing, for high reprocessing, or for high level disinfection. That should be in a specific container. And then other house keeping issues, that in your facility that linen is covered, it should never be out. If it's on carts being transferred, those carts should be covered. Pillows should not be overstuffed and put places. Those too need to be covered. there should be no paper anywhere. Everything needs to be wipeable. None of your equipment or furniture should be porous. Everything should be wiped, and so none of our fabrics for any of our chairs or sofas or anything like that that are in patient area and patient care areas or in your waiting rooms. Everything needs to be wipeable. And there's really great things that are coming out with new type of furniture for a hospital. So now we're just going to quickly do a learning activity before I open it up for a question and answer. So I invite all of you to scan the QR code, and then you can unmute yourself, or you can put the correct answers in the chat. So I'll give you a few more seconds to scan the QR code, and then we'll go through a quick learning activity, and then I'll open it up for questions. Great. So on this one, we're just going to do a quick environmental care round. So we are conducting our environmental care round. These are just some of the pictures that we see in certain areas of the hospital. So it's always recommended that you go on environmental care rounds with your group of people, and most commonly it is your infection preventionist, your environmental services, or your EVS, your occupational health representative. So that might be you or someone else. Facility engineer maintenance, your safety officer, a leader from those department. It's really helpful if they can be on the rounding, because you can help get these tasks, any deficiencies addressed immediately instead of a follow-up email. If you have a compliance or a risk officer or any other person. So definitely have a dedicating team to go on environmental services round. It's so easier. It's so much easier, and it's beneficial and time efficient, because you can address a lot of these findings, and being able to know what category they fall under those 8 that I just presented of who's in charge of it, it really helps streamline it. So this is the first question, is that we walk into our linen room and we see this. Is there a problem of what we are seeing? And should our linen with our pillows, as I mentioned, should they be covered? Do they need to be covered? Can they be partially covered? Or they're pillows, they don't really matter? What would be the best answer for this from what we were talking about? Yes, that's great. The correct answer is C, they should be covered. Pillows, linens, everything needs to be covered. Next, we walk into our supply room with our clean supplies, and we see this. Is there an issue with this? Yes, no, unsure. Yes, that's great. There is an issue. What is the issue? There's no cover to the bottom shelf. There's too many things. There's too many oxygen tanks. D, it's both of them, or it's disorganized. Yes, that's great. It's D. There's too many oxygens. The oxygen cart, as you can kind of see in this picture, it's built complete, but then there's an additional oxygen. So there's certain regulations of how many oxygens canisters can be in an area, which then kind of puts that as a fire risk, and that goes into that fire risk and life safety environmental care. Also, the bottom shelf, as I mentioned before, isn't solid. So there's ways that dirt and debris can come up and get on all levels of those containers. And if you can see, some of the containers are urine cups. So if you're getting dust and debris and pathogens on urine, then people are urinating with them, that can potentially colonize them or expose them, and you can get a UTI. Or if they have any other type of wounds in their groin, you could potentially be cross-contaminating them and exposing them to that. So next, we walk into another part of the room. Is there a problem? Yes, no, unsure. Oh, you guys are doing so great. Yes, there's a problem. Things are stacked too high. It's not 18 inches from the ceiling, so it's potentially blocking the fire sprinkler from doing their job if there is a problem. Question 5, when is it okay to put things on the floor in a room? Is it okay? Is it okay that they're in another bag, or is it never okay? Yes, right. It's never okay. Even if there is another bag, they should never be placed directly on the floor, because again, you are contaminating as soon as you set it on the floor, even though it's in another bag. When you're unwrapping it, you're potentially contaminating when then they're transferring it from within inside the bag to the shelf, and then that contaminated item on the shelf might touch another item on the shelf and then contaminate that. So that's never allowed. Things should never be on the floor. We go into our dirty utility room and we see this. How many things do we see wrong with this picture? Is it 1, 2, 3, or 4? How many things? Yes, that's great. There is quite many things wrong with this picture. So a lot of them is that one of the things on the back, I don't know if you can really see, but they have paper in the room in a very dirty room. So that's one, you don't ever want any paper. Everything should be wipeable and no signage. 2, we have overstuffed bags sitting on our sharps container, blocking our sharps container. You can see in the corner something's on the floor, and then our trash bins are not covered. So multiple issues here with that. Next, when is it okay to put something underneath the sink? We're in the same room, but now you're just turning to the sink and you see that. Is that okay? Is it okay to put it when the bins are full? Only if you place them under the sink, if that's okay, because nothing should be there. Or is it a trick question? It's okay to put the stuff under the sink. Yes, that's awesome. B, it's never okay to put anything under the sink. So then we leave out and we see the hallway, and we look up to the ceiling and we see this. Not only do we see this, but the importance of looking at the ceiling is which, yes, that's right. To assess all, we want to look at our tiles. We want to look at our HVAC system. Sometimes when you look up, you can literally see dust and debris coming out of your vents. And then you want to check for any sprinkler obstruction to make sure that you are able to get access in case there was a fire. And then second to last questions, how many clean beds are in this picture? Is there that you see? 0, 1, or 2? Yes, that's right. It's 0, because we don't know. They shouldn't be in the hallway because that's a fire risk and you are cluttering and overall reducing general safety. But 2, we don't know. Even though the bed in the corner is fully dressed, there's no documentation, no assurance that it's clean. Someone, a visitor, another staff member could have come in, they could have laid on it, they could have touched it with their dirty hands, they could be sick and passing by. And wipe their hands on the sheets. You don't know. So there's no clean beds in this picture. And that leads into our next question is it ever recommended to put beds in the hallway? And I think I kind of already gave you this answer is yes, it's never recommended to put beds in the hallway. One, it's a safety concern. It's creating clutter. You're violating your egress. Recommendations also, we're always looking for beds, and where they are, it also, if you put them in new places, they may not be sent down for cleaning or routine maintenance, so then they could be missing maintenance. So that was great. So here's the correct answers for all the questions. And I just want to really highlight that if you don't go out and see, you don't know. Unless you see, and if you don't know how to fix the problem. So really, as your role as an infection prevention and control, not only is it data looking at microbes, looking at patients, but also looking at your environment. If you're not out there seeing what's going on, if you're not rounding, if you're not talking with your teams, if you're not talking with maintenance or engineering, you might not know that there's an issue with your HVAC system, which then puts you at risk for exposure if it's affecting your negative pressure rooms. So communication, rounding, as I've said before, infection prevention and control is a group activity. And just to wrap up, I know we're right at time, but It is environmental care is very complicated. There's a lot that goes involved, but it's really important because it creates a safe environment for all of our people, places, and things within the environment, but also us. So not only as healthcare providers, but for our patients and for our visitors. So it's very important to maintain. So I welcome you guys to connect with us. Here's our general information. And then our next lecture is going to be on survey readiness. So some of the stuff that I've kind of talked about and leading into next month's lecture will be on June 5th, talking about survey readiness, talking about your survey plan, and what specifically how to categorize and do your annual APC risk, or not APC, ICP, annual risk plan and assessment. And like always, I ask you to give feedback and complete a post survey evaluation to let us know on what specific topics that you would like us to present. If there's resources, what current problems, we're here to serve you. So we want to make sure that we're presenting material for you. So I ask you all to scan your code and complete the post-survey evaluation. And if you do, you'll be entered into a lottery to win some Teffy merchandise. And then lastly, here are the steps that you will need to complete to get your continuing education hours. Again, as I mentioned, these lectures are recorded. You will get access within a week or so to the lecture in the slide deck. So these will all be in your inbox of, stepwise and the link of what you need to do to complete your continuing education hours. So I just want to say thank you, and I know we're a little over time, but I do want to open it up for any questions that anybody will that has. So feel free to unmute yourself or put it in the chat. Any questions?
Kayla, I see one from a little while ago.
Okay.
Is there an issue with having quality control, I think, QC solutions stored in the same fridge that hold vaccines, even if they're in a leak-proof container and placed at the bottom of the fridge?
Well, so your fridge should have a temperature monitor. It should be monitored 24/7, especially if it's a vaccine. Having medications, which goes into the vaccine distributing, they have other pharmaceutical regulations for it. Sometimes it is okay, and sometimes it is not. I would check with your pharmacist. They should be able to provide you with in detail if that is approved and appropriate and not, depending on what specific vaccine that you're looking at, and also the duration of the vaccine. Definitely in that fridge, you cannot have any food, any beverages, anything else. That should be dedicated as a medical equipment fridge, and maintaining your logs with that accordingly. If the QC solutions are there, I do not see why that would be an issue. But again, I would check with pharmacy to see if there is some sort of, depending on what vaccine it is, that there's other things saying that that vaccine needs to be stored in a fridge by itself. Great question. And I see that question in the chat for temperature and humidity for clean and sterile supplies. So clean and sterile supplies, so my first question is, or my first statement is, for your central supply area, so where you actually go down to CS, that has specific temperature and humidity recommendations, and it should be logged and looked at specifically. It also goes on with the space and the dimension of that room, so you'll need to find out what the actual physical dimensions are of what that needs to be maintained. For sterile supplies, they should be kept in a sterile area always, and not brought up to any common area for until the procedure is happening. Because you want to make sure that the draping in the container for that specific item maintains intact. So you shouldn't have clean supplies, like being at the nurse's station, that does not have specific regulations for temperature and humidity, like if we're doing anything for a dressing change or wound, that type of supplies doesn't. But if you're doing like a type of wound debridement and you're kind of doing more of an I&D with it, those types of supplies will require to be cleaned and maintained in certain rooms. So it just kind of depends specifically what exactly supplies you are talking about and what area in the facility that you're talking about. But Kevin, if you want to email me and ask me very specific things about that, I can help give you more guidance, but I need to know a little bit more exactly what type of supplies and what specific area. And I can help you there. Thanks. Any other questions?
Think I see just one additional question from a while back. The biomedical waste disposal is a huge question in our ambulatory clinics. Is there a resource we can obtain information from regarding what counts as infectious waste and proper disposal?
Yeah, so definitely OSHA has some really good material on their website of what it's actually categorized and if it's categorized A waste or categorized B waste and then how it's maintained. So I would definitely look at that, and especially in your ambulatory clinics of how you're getting rid of it, making sure that you are compliant with DOT, Department of Transportation, so you have it properly labeled and you have your pickup scheduled accordingly. But OSHA has some really good guidance on documentation, what it is in the subcategory of, how much blood is considered infectious. There's that. Also go back to my 102 lecture. It's on the TEPI side, and look at that. We kind of go into more details of the different categorization of waste. Dr. Susan McNellen, who is an ID physician at UT MB in Galveston, she has a special pathogens unit. She also talked about her medical waste with Ebola in that. So it kind of gives you a really high level of super, super infectious waste and how to handle it.
Great.
And then
one more. Yeah.
Okay. And then, I see the recommendation for point of care testing spaces. So my first question to you is, what type of point of care testing are you doing? Because we all call POC testing very differently. Is that for your glucometers? Are you looking for, are you in the ambulatory or urgent care ED setting that you're doing point of care testing for flu, COVID, RSV combination? So making sure when you're setting up cleaning of that you have yeah, okay, that's what I thought, glucometer. Thank you for clarifying that. So you want to make sure that you are cleaning your glucometer according to the IFU or the instruction for use for that specific device. You always want to clean before and after each use. So you want to make sure when you are setting up your zones, like say if you have a like you're at the nurse's station and you're on the I would first recommend, like if you don't have a designated clean space, which you could tape off and border or put a sign saying, this is a clean space, this is where we're doing POC testing, so that people don't have any fluids there, they don't have any blood there, and that you're talking that within operationally on your unit of, hey, this area or this zone we're doing POC testing, and then that there's signage for it. I would first then recommending wiping down with a cavi wipe or a PDI, SB, whatever type of cleaning you're doing your wet contact time. So then you have a clean environment to do your POC testing. And then you're, setting it up and you're doing your controls, you're doing your testing. And then you're wiping it down accordingly and letting that wet time sit for that before going on to the next one. So my first recommendation is, okay. And then I noticed that some of our clinics use their dirty glove. So their dirty glove, yes, you should do hand hygiene and then changing gloves and then making sure that they are used to that. Before they do POC testing, they should, wipe the area down, wipe the dirty, so you're coming to the nurse's station or to the other table, you're wiping it down. They can leave their dirty gloves on after they're wiping it down because it's dirty and now it's clean. Now you take off their gloves, have them take off their gloves and put on new clean gloves. Because this is a clean area, you need clean gloves. And then do your POC testing and then wipe it down. So yes, they should be doing a glove change in that area when they're doing POC and then making sure that they understand that. That they're not using, like what you said, dirty gloves on the instruments and then wiping it down. So I think that sometimes comes back to more education and more coaching. And then making sure there's good adherence by when you're monitoring and doing direct observation that they are changing their gloves for that. Because yes, I would say surveyors would, if they're literally getting the samples, which then the gloves are dirty and then they're setting it down, they should be cleaning that area, changing their gloves down, their clean gloves. So also that it's not cross-contaminating their POC samples and that they have true accurate readings too, in case that there is, you know, some crossover from their dirty gloves onto the instruments. Does that help? Okay, great. Any other questions? Awesome. Well, thank you all for attending. Feel free to email me. If you don't feel comfortable asking the questions here on the platform, not a problem. Email me. I'm more than happy to help and give recommendations and guidelines when I can. And hopefully I will see you all in our next lecture talking more about survey readiness. We kind of alluded to a lot of it in the environmental care rounds, and then now we'll talk more about survey preparation and making sure that we're always survey ready for our next visit. So I just want to thank you all for coming, and I hopefully will see you next time.